Welcome, and thank you for joining my presentation on sexual addiction, a case study with approaches and considerations for Black men. Today is December 3rd, 2025, and my name is Leslie Jones. Let us go over the agenda. For today's agenda, I will cover background on sexual addiction, give a case conceptualization of Chris, compare two treatment approaches, go over relapse treatment, and cover cultural, ethical, and other considerations, and finally give recommendations with my conclusion. Background on sexual addiction. Definition. It is estimated that about 3 to 6% of the U.S. population may have a sexual addiction. Sexual addiction is a process addiction with both positively and negatively reinforcing behavior that individuals experience, seeing this dynamic used to feel better and regulate their emotions. As author Giordano states, sex is a natural and physically rewarding behavior and is required for reproduction of our species. It exists on a continuum from healthy sexual behavior in the middle of the extremes of sexual anorexia and sexual addiction. Sexual addiction treatment does not focus on sexual acts, but instead on the client's relationship with sexual activity, their loss of control over their sexual activities, and preoccupation with sex. Individuals experiencing sexual addiction use sex for pleasure, to escape pain, and to numb themselves. In this sense, process addictions and substance addictions are the same. Though process addictions, such as sexual addiction, have similarities to substance disorders, they are often viewed as distinctly different by researchers, counselors, and the general public. The two types of addictions can serve familiar functions for the individual experiencing the addiction, share symptoms, have similar causes, and similar approaches to treatment. There are several apparent reasons why process addictions are still not considered the same as or not as severe as addictions to substances and thus receive less attention in research, diagnostics, and funding. According to Alavi and colleagues and Creeder, there are conflicting views over the way in which the quote-unquote substance of the addiction is consumed and about the way in which any physical signs will present. Perhaps because one cannot see the literal consumption of a substance in a sexual addiction like one can clearly see a substance being drunk or snorted, it is naturally difficult to understand that the same or similar dynamics are going on in the brain for both types of addiction. In this case, it seems that if one cannot see it, one cannot believe it. Educational requirements for treating sexual addiction include a master's degree in a mental health related field and also additional experience, training, and certifications that are above and beyond the aforementioned degree to obtain licensure. In 1983, sexual addiction, a term coined by Richard von Krafft-Ebing, was a new concept. Historically, sexual addiction refers to out-of-control sexual activity that one continues to engage in despite significant negative consequences. The idea of excessive sexual behavior is rooted in medicine, going back to hyperesthesia, which is a condition involving self-abuse and overly increased intense libido. Common terminology for males include Don Juanism and satyriasis, along with nymphomania for females, as well as general terms such as hyperphilia, impulsive or compulsive sexual behavior, and out-of-control sexual behavior. Sexual addiction was even considered a paraphilia-related disorder. It is traditionally treated with the 12-step model similar to Alcoholics Anonymous. Examples of these programs are Sex Addicts Anonymous, Sexaholics Anonymous, and Sex and Love Addicts Anonymous. These are social support groups with the aim of supporting individuals with a sexual addiction in various forms. From a historical social perspective, the label of sex addict and its related assumptions have sometimes pathologized normal sexual behavior, which has led to stigma and shame because the behavior may not conform to everyone's idea of what is considered to be normal sex. Unfortunately, like other addictions, individuals experiencing sexual addiction today often carry great shame and must deal with significant trauma. Interestingly, while there is a diagnosis for male hypoactive sexual desire disorder in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, neither sexual addiction nor hypersexual disorder has been formally classified in the current DSM. Reasons for this include a lack of substantial clear research and a concern that developmentally appropriate sexual exploration in young people under the age of 18 could be labeled as a pathology, which could lead to children being inaccurately categorized as sexual offenders in the legal system. This would be extremely unethical. Excuse me. However, according to Giordano, in the International Classification of Diseases 11th revision, or the ICD-11, does include a section on disorders of impulse control in which they list compulsive sexual behavior disorder. Additional diagnostic considerations include using the ICD-11 behavior code and or diagnosing co-occurring disorders, if applicable, to facilitate treatment. Finally, impulse or conduct-related disorders with the hypersexual or disorder qualifier can be leveraged. For the purposes of this presentation, I will cover the approach that works best for my case study client, Chris, considering his needs and context. Overall, more men present with sexual addiction than women, though it is not just a problem for men. Furthermore, there are more cases in late adolescence and early adulthood between the ages of 20 to 30 years than there are for more aged adults. Genetic susceptibility, along with early attachment or trauma issues leading to poor coping skills and poor emotion management, tend to be reasons why sexual addiction occurs. Specifically, insecure attachment styles are correlated with compulsive sexual behavior, while trauma, especially early in life, can cause changes in the brain, influencing the potential for such behavior as well. Those ideas relate to what is considered a more classic sexual addiction. However, a newer, more contemporary type of rapid onset sexual addiction has developed in parallel to online technology. Specifically, early experience with graphic online material can disrupt healthy neurochemical, social, and sexual development in young people and lead to a sexual addiction. Many individuals experiencing sexual addiction have a history of coexisting mental health conditions such as anxiety disorders, personality disorders, other addictions, obsessive compulsive disorder, ADHD, and mood disorders such as bipolar disorder. Outcomes of sexual addiction can be similar to other addictions, yet also specific, and are devastating. The individual may feel guilt, remorse, or shame, hopelessness, powerlessness, depression, isolation, fear, and may even become suicidal. They may experience financial troubles from spending money on sexual activities, poor relationships with loved ones, including poor sexual relationships, and have low self-esteem, health issues from unprotected sex, poor sleep, and ignore obligations, lie about their activities, and feel strong incongruence with their personal or religious values. The average age that someone with a sexual addiction reaches out for help is about 37 years. A positive prognosis requires a lifelong commitment to manage one's behaviors, desires, and excessive thoughts. Relevant theories. Theories of sexual addiction come mainly from cognitive behavioral therapy, psychodynamic theory, and neurobiological theory. The authors argue that a more holistic and integrated approach is appropriate. That is what has developed more recently. Riemersma and Sytsma state that as of 2013, there has been more research done than within the previous 30 years. However, there is a general lack of agreement about the etiology and nosology of the condition, which has led to disagreement on what should be the measured focus of sexual addiction research. This begs the question of how to best measure the concept of sexual addiction. Would self-report or observation yield the most accurate research results? This concern was further confirmed by Grubbs and colleagues, who indicate that methodological designs in sexual addiction research over the previous 20 years were based on simplistic methodologies and were lacking theoretical integration and quality measurements. This does not make sexual addiction any less real for clients who are suffering with this dynamic. Current treatment approaches and trends. Current treatments for sexual addiction can be similar to other forms of addiction, and the recovery process these days can take from about 3 to 5 years. It's a process dealing with the whole person. Initially, one would need to determine the type of treatment required from what is available, whether in or outpatient, intensive outpatient, or residential, and so on, and whether individual, family, or couples counseling is advisable. Typical interventions are cognitive behavioral, psychopharmacological, and 12-step programs. Clients must not engage in compulsive sexual behaviors and must deal with emotion regulation, attachment issues, adverse childhood events, shame, and guilt where present. There may be an initial period of abstinence from all sexual activity to try and reset the client's dysregulated reward system as a first step, similar to substance use detoxification. Without performing their compulsive sexual behaviors, they must also grow to incorporate new productive coping mechanisms and ways of dealing with adversity. It is possible the client will develop additional addictions during this process. Multiple addictions are rather normal and should regularly be considered, as it is commonplace, with about 69 to 80% of men and women developing at least one coexisting addiction. Counselors should address these simultaneously, if possible, as a group of interacting behaviors. Comorbid mental health disorders are also common and expected, with women presenting often with eating disorders and anxiety, and men presenting often with sexual dysfunction, substance use disorders, and depression. This dynamic needs to be accounted for and addressed with the client. Additionally, counselors must be able to hear information and details about the client's life and activities, which may startle us, and we should not show shock. Compassion and curiosity for the client is important. We must also discern inconsistencies in what they share with us. Last, counselors must understand trauma and grief and maintain the skills to assist our clients with processing their difficult experiences along with the shame and guilt they likely feel. Additionally, psychoeducation is key. As touched on above, trends in sexual addiction include reducing shame and guilt the client feels, leveraging an integrative approach to treatment, understanding the wide range of online sexual addiction activities in which a client may engage, and being aware of emergent rapid onset sexual addiction. Previous research has been deemed inefficient, and an attempt to improve this is ongoing. Populations with sexual addiction seem to be growing, and counseling for this condition is ever imperative. Case conceptualization for Chris. Deconstructing Chris. The focus of my particular case study is Chris, an African American or Black adult male who is behaving in ways that he feels are deeply uncomfortable. Specifically, he is engaging in multiple extramarital sexual activities and feels he is out of control. These behaviors include public sex, frequent masturbation, sex outside his marriage, escaping through pornography, sexting via chat rooms, paid private time with others online, and having an in-person anonymous sexual affair. This started about 3 years ago when he began having intense sexual urges that he was uncomfortable with sharing with his partner because he thinks they will judge him. At this point, Chris's extramarital experiences provide him with social connection, sexual expression, and mood regulation, to name a few of the needs being met. However, he is experiencing significant negative consequences such as fighting and disconnection from his partner, anxiety or his partner or wife, his wife, anxiety and fear of being discovered by his partner and children, confusion, depression, shame, and guilt from a conflict between his behavior and his religious beliefs. His urges are only getting more intense. He feels severely alone in his suffering and may fear abandonment from his partner should they learn about his urges and behaviors. He presents as wanting to understand himself and change some of his behaviors. The main red flags here are that Chris says he feels out of control, is using various sexual experiences to modulate his emotions, and is continuing to engage in these actions despite significant negative consequences. As his counselor, it is my role to help Chris understand his behavior and then help him clarify his goals for himself and his marriage, while also teaching him skills for better managing his emotions and central nervous system. I'm also interested in his feeling of disconnection and why he thinks his wife will not accept him. Considering what has taken place to this point, his marriage to his soulmate and high school sweetheart may be at grave risk, and the fact is that if his wife finds out about his activities, they may exit the marriage. He must face that potentiality. On the other hand, his partner may accept his desires and understand his struggles, bringing them closer and leading them to a more satisfying relationship with authentic understanding, acceptance, and connection. There is also the potential that Chris may decide to leave the marriage anyway on his own accord, depending on his goals. Chris feels desperate to me. His misery seems extremely poignant and serious. I want to interview him and determine what is encouraging his, as he calls it, undesirable sexual activities. I want to determine whether his partner, his wife, whether he wants his wife to know about what he is going through. A biopsychosocial interview and formal assessments will be useful here to better understand Chris. I picked this case study because on some level, as I've been married for almost 20 years, I can relate to Chris. Further, I can see that Chris desperately needs and actually wants help. His readiness is relatively high. I feel real empathy for Chris, even though this is just a case study, because the situation is so real. He probably feels horrible about himself and even admits he is very confused. I hope he and his wife are able to grow together through this, but only if that is what Chris wants as well. Considering the above, one goal is to determine the underlying drivers of his behavior, such as sexual or other trauma, anxiety, depression, a mood disorder, or impulse control disorder. Some of these items can be addressed generally through the PHQ-9, Patient Health Questionnaire, and the GAD-7 for generalized anxiety disorder, for example, which measures presence and severity. They measure presence and severity of depression and generalized anxiety, respectively. According to the International Institute for Trauma and Addiction Professionals, the IITAP, and sexhelp.com, sexual addicts, often have experienced sexual trauma or abuse at an early age. It is critical for the counselor to understand Chris's experiences. However, the professional alliance must be strong, and Chris must trust me in order to divulge these types of secrets he may be hiding, along with any other traumas that he has experienced. He has noted that his intense sexual urges started about 3 years ago. It is extremely important to understand what precipitated this onset of drives. It is possible that something triggered Chris at that time, which initiated his desires and their being so strong. With a strong alliance, perhaps Chris will explore this with me. One case conceptualization to consider is that he also has an anxious attachment style, which was triggered about 3 years ago through events that can be explored. Alternatively, something traumatic may have occurred just 3 years ago that initiated his sexual acting out. These are dynamics to be determined or discovered. A third potential reality is that Chris's sexuality is broader than he previously realized. Perhaps he is bisexual, for example, and needs a venue to express these desires. He may have been hiding his tendencies so that his wife would not leave or reject him. However, the first two options are more likely, as he is modifying his emotions through his sexual activity, which is common in sexual addiction. It is not only a question of his sexual preference. Assessing and diagnosing sexual addiction. Accurately identifying sexual addiction or compulsive sexual behavior is fundamental to providing effective treatment for the condition. While there is no formal diagnosis in the DSM, as mentioned previously, compulsive sexual behavior disorder is listed, as I said, in the 11th edition of the ICD. Because there is no formal diagnosis specifically for this behavior in the DSM, formal assessments are not prevalent. In assessing for sexual addiction, counselors can begin to assess for the condition by gathering basic information. Initially, one must determine whether the client is under the influence of any medical conditions or substances that may contribute to compulsive sexual behavior. In addition, counselors should determine any presence of axis 1 disorders such as bipolar disorder or psychosis, and also exclude a personality disorder. Furthermore, the client must indicate a feeling of loss of control, continuing to engage in the behavior despite repercussions and negative impacts on the client's life, and being preoccupied or even obsessed with sex and their sexual activities. As mentioned previously, clients will often feel dissonance between their behavior and values. Their behavior may be unsafe and disrespectful of others, decreasing intimacy with important loved ones. Once these qualifiers are solidified, a formal assessment for sexual addiction should be considered. In diagnosing Chris, it may seem at first glance that it is easy to indicate that he has a sexual addiction based on the fact that he feels out of control, uncomfortable, and does not know how to stop. However, one also must consider alternative and/or comorbid diagnoses. Additional conditions such as major depressive disorder are also noted as being linked to sexual addiction. In ruling these comorbid and alternative diagnoses in or out, one must consider the symptoms that Chris reported. He says he's experiencing depression, does not mention mood swings of any kind, and may have attachment considerations as referenced by him not thinking that his wife will accept his desires. However, he does not present as having a personality disorder. Thus, bipolar and/or personality disorder are dismissed as diagnoses at this time. Furthermore, the two additional conditions may also be considered that are more closely related to sexual addiction. They are an addiction to just pornography and cybersex, or an addiction to love, the emotions that come with it, the limerence. Chris mentions he has engaged in pornography and cybersex. However, he also has had anonymous sex in person, so his is a broader pattern of behavior. He does not appear to qualify for just a pornography and cybersex addiction. Furthermore, again, because he does not mention being in love or note the limerence associated with love, he does not appear to meet the requirements for that disorder either. As mentioned above, there are not a plethora of choices for formally diagnosing sexual addiction. For example, a search on SAMHSA yielded no reference to a sexual addiction or compulsive sexual behavior assessment. However, there is the SAST, the Sexual Addiction Screening Test, which is a 25-item measure. There is also the SAST-R, which is the same test but revised. It's a 45-question self-reporting formal assessment with a 20-item core and cultural and sexual orientation subgroup updates. Further, there is a division derived from the initial version, just the SAST, and this one is called PATHOS, P-A-T-H-O-S. It's a 6-item version of the SAST-R, actually. Sorry. While this quick assessment appears useful, it does not gather the detail possible with the SAST-R. The SAST-R has solid psychometric properties. Internal consistency ranged from 0.868 to 0.904, depending on one's sexual preference subgroup. This assessment is able to determine clinical versus non-clinical cases. It can be leveraged within different spaces, such as private therapy, the criminal justice system, treatment centers, and community-based programs. I therefore selected the SASTR, one of the most widely used assessments on compulsive sexual behavior. According to Carnes, out of the 45 items on the sexual addiction assessment, 6 or more core items, 3 or more internet items, and 2 or more MINS items must be endorsed for sexual addiction of those subscales. Severity is measured through loss of control, preoccupation, affect disturbance, and relational disturbance. 2 or more of any of these categories endorses significant impairment within that dimension. The higher the total score, the more severe or comprehensive the addiction. The assessment is free and self-scoring via an easily accessible online application from psychologytools.com. An overall score of 7 or above is consistent with sexual addiction. If found to be a potential or likely candidate, there is a link to select a licensed therapist should the client want to get help for themselves. While there are no apparent sexual addictions assessment meant specifically for Black men, the SASTR has been cross-culturally adapted and used in several countries. It was also revised, as I said, for sensitivity for sexual preference and gender. Furthermore, the assessment was developed in English and translated into Persian, Hispanic, and Polish versions, with studies also completed in French. It is therefore appropriate for clients of diverse backgrounds. For the purposes of this case study, and based on the criteria outlined now, I am assuming that Chris has now taken the SASTR assessment with a significant score above 7, indicating that he does suffer from sexual addiction. Assessing and diagnosing depression. Having determined the aforementioned, it is also noteworthy that Chris is using sex as an escape to improve his mood and is depressed. It is becoming clearer that his sexual activities and depressed mood are intertwined. Depression is a disorder for which he should also be assessed. This will be accomplished by formally assessing via the Patient Health Questionnaire 9 or PHQ-9. According to Kroenke and colleagues, major depression is diagnosable when 5 out of 9 criteria for symptoms are noted as present for more than half of the days in the previous 2 weeks, as long as one of the depressive symptoms is anhedonia or depressed mood. Thoughts of death or desires to hurt anyone, including oneself, are a big red flag for diagnosing major depressive disorder. Any physical or medication-related causes of depression, history of mania, and normal bereavement must be ruled out. Severity of the PHQ-9 runs from 0 to 27, as each of 9 items score from 0 to 3. Additionally, the difficulty of each problem or symptom is noted to inform severity. For this assessment, the severity score for depression is 16. Cutoff scores are 5 for mild, 10 for moderate, 15 for moderately severe, and 20 represents severe depression. Chris would need to endorse at least 5 symptoms with a severity of 16 or higher for a diagnosis of major depressive disorder. My assumption for this case study is that Chris has met the criteria for major depressive disorder. With these diagnostic outcomes, it will be important to consider the severity of his compulsive sexual behavior with the severity of his depression. Knowing how these compare can help determine the focus of treatment going forward, with the caveat of not having an approved formal DSM diagnosis available for his compulsive sexual behavior. At this point, it appears useful and accurate to work with a formal depression diagnosis. One does not want to overdiagnose, even by leveraging the ICD-11 compulsive sexual behavior disorder category, especially when trust is an issue between counselor and client, which is often the case when Black clients have white counselors like myself. Plus, I'm a woman. Furthermore, Chris is ashamed of his behavior and may not want a sexual addiction diagnosis, which would be appropriate if in fact his depression came first and his sexual behaviors are an attempt to manipulate his emotions and feel better. Through the justification above, one can understand why it would be appropriate to diagnose Chris with major depressive disorder and note his compulsive sexual behavior a bit more informally. It's a big deal that there is no DSM-approved diagnosis. A depression disorder with comorbid compulsive sexual behavior can facilitate his mental health insurance payments and yet still allow for treatment of his unwanted behavior, potentially through CBT and medication therapy, for example, while not labeling him with something he is definitely afraid of being known for. Furthermore, as his compulsions are likely directed to his depression, treating the root cause, the depression, can help address his unwanted behavior. With further details, a different approach may be settled upon. However, with what the research points to, what Chris has communicated, the availability of diagnostic categories, and some cultural considerations, the above diagnostic approach and diagnosis makes sense. Levels of care. The concerns discussed so far and likely trajectories give structure and point to a potential approach for appropriately treating Chris within the correct level of care. Outpatient, intensive outpatient, and inpatient treatment may all be reasonable here. However, I would not initially secure intensive outpatient or inpatient treatment at this case. In this case, at this point, it could be a hard sell for a client who may not trust me, as I said, at all in the beginning, which could result in Chris disappearing from counseling and never showing up again. There are some inherent limitations for treating Chris. One additional reason that I'm not considering intensive outpatient or inpatient treatment at this initial time is that Black men are not well represented in many formal treatment approaches. This can impair treatment success if they continue to feel isolated in treatment and/or are being discriminated against. I need to proceed carefully with Chris and not overwhelm him with too much treatment too soon, especially without clearly understanding the motivation for his behavior and severity of his symptoms. At the same time, I do not want to avoid providing treatment he actually needs. It's a matter of his awareness and acceptance of his condition and subsequent readiness for the distinct levels of treatment. It may be that he could benefit from various levels, but only if he feels understood and trusts his counselor. Additionally, I would seek consultation along the path of treating Chris and be careful to balance treatment with readiness and severity. Therefore, my inclination is to treat Chris in an outpatient structure and continue to strengthen the alliance between us, and at the same time continue determining the underlying causes and severity of his urges and behaviors. In addition, a peer support group, perhaps faith-based, can help alleviate his feelings of isolation and shame that are typical of sexual addiction. Finally, if after these details are solidified and Chris still feels out of control and overwhelmed, an intensive outpatient or an inpatient sex addiction treatment center could be appropriate. Considerations. Also important is to gain Chris's cooperation in getting him tested for sexually transmitted diseases. This is not only key for Chris's health, but for protecting his wife as well. What his wife does not know can hurt them. Not including this effort in his treatment would be an ethical mistake against Chris and his wife, who at this point has no idea that they are in jeopardy. Again, Chris's trust is paramount if he's going to be able to work with me productively and agree to testing. After testing, if he is positive for any diseases or conditions, a new level of treatment may become necessary to address the potential outcomes of HIV, AIDS, or other illnesses that become apparent. At that point, Chris may need appropriate hospitalization if he has a serious illness that needs extra care to address other than what outpatient therapy can cover. And I would be remiss here if I did not mention that there could be an ethical dilemma related to Chris putting his wife or others in danger of diseases. If he has a sexually transmitted disease and does not notify his wife, she would be in serious risk of him transmitting any number of viruses and bacteria to her and not even be aware of the danger. I may have to break confidentiality to protect his wife and others with whom he continues to engage in sexual activities if he is shown to have anything transmissible. I would certainly seek consultation on this situation. Finally, when appropriate and depending on his age and worldview, it may be useful to bring in some of Chris's family, such as his wife, mother, perhaps. It would depend on whether he wants his wife to know and wants to save the relationship. Additionally, we do not know his exact age, but that he is a young man. Furthermore, if, for example, he maintains a collective worldview, this inclusion could be productive. Also, if his mother is an important figure in his life, her inclusion may add support. Chris mentioned he does not want his children to know of his behavior. I see absolutely no reason his children would need to be involved in understanding his sex life unless he is coming out sexually and wants to include them on this, depending on their ages. Chris presents as having readiness to make changes once he understands why he is behaving this way. Having thought through multiple approaches to this case study with Chris, it has become clear that his diagnosing process, outcome, and severity are key to everything that follows, such as level of care and selection of interventions. Research on treating minorities for sexual addiction is limited. Having been diagnosed with compulsive sexual order and compulsive sexual behavior and major depressive disorder, Chris is poised for treatment. The framework for this treatment at a high level would consist of outpatient care and peer support specific to his gender and race, if at all possible. Being Black and likely viewing family and life through a collective lens, including those close to him, could be productive. However, that is a sensitive topic and depends on Chris's goals for therapy. Additionally, he should undergo a medical exam. Chris is ready for treatment. Enacting the most beneficial level of care treatment is a process of learning about his specific situation and needs and balancing those against readiness for differing types of therapeutic approaches. Consulting about Chris is important for selecting the best treatment at the most beneficial time. Trust is our cornerstone, especially as he is a young Black man. I will need to work hard and smart to gain and keep that trust and help Chris reach his goals. Comparison of two treatment approaches. Cognitive behavioral therapy. Cognitive behavioral theory holds that learned thought patterns and behaviors affect one's personality, emotional states, and other behaviors. Distress develops when one's maladaptive thoughts result in emotional and cognitive dissonance because of one's perception of their situation, and not necessarily from the actual situation itself. According to New Krug, cognitive behavioral theory purports that cognitions and behaviors have been learned and can subsequently be relearned or unlearned and relearned when they are maladaptive, which moves the client from psychopathology to health. CBT can be combined with psychodynamic, existential, or other approaches for a more holistic means of healing compulsive sexual behavior. Combining approaches can be better than just applying one or the other. While psychodynamic approaches can go deep into the mind to solve unfinished business from childhood, CBT is great at teaching emotional and physical regulation through healthy coping skills and is also effective at treating depression. Counselors need to be knowledgeable about CBT and how to facilitate it. Skills such as teaching relaxation techniques, mindfulness, scheduling activities, journaling, identifying negative thoughts, reframing, increasing metacognitive awareness, and solving problems are extremely useful in this case. CBT leverages a number of techniques, change programs, distraction, challenging beliefs, acceptance and commitment, cognitive restructuring. These techniques can help Chris change his thought process and subsequently his emotions and behaviors, including helping how he regulates his nervous system. Regulating his nervous system is not directly addressed through psychodynamic intervention, so CBT would be a useful addition with even existential theory in order to address Chris's compulsive behavior in a more holistic, immediate approach where he can get quick relief as opposed to only leveraging the psychodynamic approach, for example. These more rapid positive outcomes may make him more likely to stick with counseling because he can see benefits more quickly. According to Shepard, Chris may see results as soon as after the first counseling session and generally within the first months of treatment. Though the evidence for CBT is strong across an array of populations, studies have been mostly conducted on white women. This could be a limitation. Roles of the counselor include teaching the client specific techniques for changing their processes, thus influencing their emotions and behaviors. Once the client can apply these techniques to themselves, they gain control and power over their condition. This is an incredible win for individuals experiencing addiction. One potential weakness or risk is that this approach does not directly delve into past issues. Without addressing past traumas, for example, only using CBT can risk the client relapsing because the original issues causing the problem are not resolved. However, CBT is great for helping individuals relatively quickly and effectively. Existential counseling approach. As a comparison, I am going to talk about existentialism. Chris presents with being confused about how to make desired changes to his behavior. This stems largely from religious and personal value conflicts he is having over his sexual activities, and he wants to move forward with more direction. An existential approach can help him gain more clarity on what he truly values and provide direction to make decisions that help him move forward. Existentialism is rooted in the concepts of death and non-being, freedom, meaning in life, moral and existential guilt, and authenticity. Existential beliefs are that the world has no inherent purpose or meaning, and people are not good or bad, yet we are responsible for creating meaning through our choices. This heavily relates to Chris. His behavior is going against his values, he is confused, and does not know how to move forward in a productive manner. An existential approach to help Chris rediscover his important values can give him the direction and freedom to make different behavioral decisions moving forward. Additionally, there is support indicating that existential concerns can affect one's sexuality. Furthermore, lower religiosity has been linked to higher pornography use. As an example, by guiding Chris through an existential exploration of his spiritual and religious values, he can clarify what it is that he really wants in his overall life and then decide to make changes based on value conflicts. In addition, a discussion about his thoughts and feelings related to his wife can help him determine how he wants to proceed with her. He may or may not divulge his secrets to her, but his intentionality is key here. Knowing how he wants to address his wife going forward will give clarity and directions to the next steps he takes. The duration of an existential approach is longer than CBT. The duration also depends on how ready Chris is to make permanent changes in his life. It may take some clients longer than others to be able to actually make changes based on a rediscovered life direction. One limitation and risk is that existentialism does not address coping skills as directly as CBT, which could cause a relapse due to a lack of skills by the client and to manage themselves and cope better. In addition, though an existential approach focuses on life's meaning, which virtually every human sees as important, it is also heavily rooted in Western culture. However, research on existential therapies, especially meaning-oriented therapies, has shown that it has positive effects on physical and psychological quality of life and well-being. Relapse treatment. Mindfulness-based relapse prevention. Relapse is common among those experiencing addiction. Relapse treatment helps clients understand how they relapsed and helps them move forward with more armory to not relapse over and over. One approach to relapse prevention is a mindfulness-based relapse prevention model. Mindfulness-based relapse prevention, or MBRP, is a relatively new model for addressing sexual addiction. This model combines mindfulness-based stress reduction techniques through mindfulness training and CBT aimed at developing relapse prevention skills. Developing these skills helps enable clients suffering from sexual and other addictions to become aware of what triggers their addictive behaviors, and strengthen their ability to manage uncomfortable experiences. These systemic practices can help Chris not focus so heavily on his cravings and overwhelming thoughts surrounding his sexual experiences. By leveraging MBRP, he can learn to better tolerate uncomfortable states by observing them, yet not acting on those challenging states repeatedly. In a preliminary pilot study, research supports the reality that MBRP may result in better control of one's sexual addiction-related thoughts and actions. The model has been shown to be effective for multiple substance addictions, problem gaming, obsessive-compulsive tendencies, and mood disorders, as well as sexual addiction. According to Holas and colleagues, there is support showing that MBRP also can reduce emotional discomfort from anxiety and depression, lessen excessive viewing of pornography, and somewhat lessen masturbation and coupled sexual activity. Furthermore, according to Holas et al., there is an inverse relationship between hypersexuality and mindfulness, which indicates that more mindfulness, according to MBRP, equals less hypersexuality. This evidence bodes well for Chris, who is not only suffering from sexual addiction but also depression, both of which can be treated with mindfulness and CBT as indicated in the relevant empirical research noted above. Roles enacted in MBRP allow for the client to self-soothe or self-administer to their triggers once they have learned how to facilitate the mindfulness and CBT interventions. Any qualified counselor or mental health specialist can teach Chris about MBRP. Once learned, he can independently help himself, which will give him a feeling of control, which is important for preventing relapse. In general, key elements of relapse treatment include providing psychoeducation to the client about the social, physical, and emotional aspects of their addiction. It must help clients identify what they are feeling and what defenses they put up against those feelings. Committing to developing a support system is also important with involving family members. This must be an ongoing commitment. The main point of MBRP is to address uncomfortable feelings with new stress management skills. Relapse prevention must also be culturally appropriate. Psychoeducation and community and family support should also be a part of effective relapse prevention whenever possible, which would be culturally appropriate for Chris, as typically Black men have a collectivistic view. In the end, it is not often that one approach can cover all client needs. Simply combining the above key elements can work well. It is notable that sexual addiction is not well addressed in treatment and recovery, especially for Black men. Limitations include that more research needs to be conducted on the effectiveness of MBRP to garner more support for the model specific to sexual addiction. The study was vetted on white males. Despite these limitations, MBRP can give Chris skills to immediately and effectively manage challenging thoughts, feelings, and behaviors. That ability and sense of control can be a big advantage to someone like Chris. Cultural, ethical, and other considerations. Chris. Ethnically, as a minority, Chris must be approached through a culturally responsive lens. This becomes a bit challenging when most empirical research is usually westernized and focused on white men and women. However, by incorporating elements of multiculturalism, such as using a collectivistic approach and being aware of the sensitive issues around Black men in the medical arena, a sensitive counselor can help Chris meet his goals and move forward. For example, as a young Black man experiencing sexual addiction and depression, it is important to connect him with others so that he can address his isolation and loneliness collectively with like others. Asking Chris to join a local Sexual Addicts Anonymous peer group with other Black men suffering from sexual addiction can join him with others like himself. This may be difficult to find, but worth it if he can find such a group. In an effort to reduce shame, which may be felt very strongly by Black men, psychoeducating Chris on the dynamics of addiction and recovery, including the biology of addiction, can take some of the pressure off by helping him understand that it is not all his fault and is a natural dynamic that has gone awry. Understanding these realities can reduce the shame that Chris is feeling and let him know what he is experiencing and that this is not his fault and he is not a bad person for having a sexual addiction and being depressed. Recommendations and conclusion. Recommendations for Chris. Overall recommendations for treatment are to provide culturally responsive outpatient care with elements of combined CBT and existential therapies, a peer support group with like individuals, and psychoeducation, and include his family, that is his wife and mother, if that is what he needs and is ready for. He should expect to develop better coping skills and direction in his life through these counseling approaches. Future work could include trauma and grief work based on Chris's past experiences. Although not mentioned in detail previously, medication also should be considered for his condition, both conditions. I want to thank you for your time today and being curious about this topic. I hope it has been useful and you have learned something about sexual addiction and its effects on individuals experiencing this condition, along with some effective treatments for it. Hope you have a great rest of the day. References follow.